This case report, published in Veterinary Medicine and Science, details an unusual presentation of suspected steroid-responsive meningitis-arteritis, or SRMA, in a 2-year-old female golden retriever. SRMA is an immune-mediated inflammatory disease that affects the meninges and arteries, typically in young dogs under 2 years old. The affected dog initially presented with subdued behavior and reluctance to use stairs. The case is notable because the dog experienced epistaxis, or nosebleeds, and intradural-extramedullary spinal hemorrhage, and did not display the typical clinical signs of cervical or thoracolumbar hyperesthesia, which is neck or back pain. The dog's diagnosis of SRMA was supported by her signalement, blood work, cerebrospinal fluid or CSF analysis, and response to corticosteroid therapy. The study begins by introducing SRMA as a condition usually found in young dogs that typically presents with fever, lethargy, and acute cervical discomfort. This discomfort often manifests as neck rigidity and reluctance to move, with neurological deficits usually absent. Routine blood work often reveals leukocytosis, which is an elevated white blood cell count, and an increase in C-reactive protein, or CRP, which is a marker for inflammation. The diagnosis of SRMA is often supported by the signalement, clinical signs, blood work, CSF analysis, and the dog's response to steroid therapy because there is no specific definitive diagnostic test available. Treatment involves immunosuppressive doses of corticosteroids for several weeks or months, usually resulting in clinical improvement. Hemorrhagic myelopathy, or spinal cord hemorrhage, is rarely reported in dogs with SRMA, and is believed to be caused by structurally weakened blood vessels. Previous studies of spinal hemorrhage have found SRMA to be a causative factor in 20% of cases. The case history begins with the 2-year-old golden retriever's initial presentation, where she was subdued and reluctant to use stairs. She was examined by an emergency service for acute lethargy and inappetence. Her physical examination was unremarkable except for a fever of 39.6 degrees Celsius. Blood gas analysis and electrolytes were normal, and she was treated with paracetamol for fever. The next day her temperature was normal, but a complete blood count revealed leukocytosis, neutrophilia, which is elevated neutrophils, and thrombocytopenia, which is a low platelet count, although this was thought to be due to platelet clumping. Serum biochemistry showed mild elevations in alkaline phosphatase and cholesterol, and a CRP concentration greater than 70 mg per liter, which is elevated. Meningitis was considered a differential diagnosis due to her history, clinical signs, and elevated CRP, and a referral to a neurology service was recommended. At the neurology service, the dog had a normal physical and neurological exam, but then developed pelvic limb ataxia and rapidly progressed to non-ambulatory paraparesis. A repeat CRP concentration was 113.8 mg per liter, which is elevated, and the neurological exam suggested AT3L3 myelopathy or AL6S3 myelopathy. No cervical or thoracolumbar hyperesthesia was noted. A vascular, inflammatory, or neoplastic process was suspected, and there was no known history of toxin ingestion. Magnetic resonance imaging, or MRI, of the thoracolumbar spine was performed. The MRI revealed a well-defined intradural-extramedullary lesion on the right ventrolateral side of the spinal cord at the caudal aspect of L2. The lesion was oval in shape, measuring approximately 1 cm long by 0.4 cm wide by 0.5 cm high. The lesion was hyperintense on T2 weighted images and mildly hyperintense on T1 weighted images, with mild, uneven contrast enhancement, and was causing spinal cord compression. The source text includes 3 figures that illustrate the MRI findings. Figure 1 has 2 parts, A and B, that shows sagittal views of the thoracolumbar vertebral column. Panel A is a T1 weighted image, and Panel B is a T2 weighted image, with the lesion indicated by a red arrow. Figure 2 has 3 parts, A, B, and C, that show images of the thoracolumbar vertebral column. Panels A and B show sagittal and transverse views respectively, using T1 weighted and T2 weighted images respectively, while Panel C shows a T1 weighted image with contrast, where the red arrow indicates the lesion. A lumbar tap resulted in a blood-contaminated CSF sample, so a cisternal tap was performed. The CSF was visually xanthochromic, and analysis revealed a marked mixed pleocytosis, which is an elevated white blood cell count, with a slight neutrophilic predominance, a moderate erythrocyte presence, and elevated protein content. Based on the neurological signs and MRI, an intradural-extramedullary hemorrhage was suspected as the cause of the dog's myelopathy. Testing for Angiostrongylus vasorum and other infectious diseases was negative. Treatment was initiated with a single intravenous dose of dexamethasone, but the dog's condition worsened. Surgery to decompress the spinal cord was then discussed. The surgical procedure involved a right-sided hemilaminectomy at the L2/L3 level, and a durotomy. During surgery, the dog's bleeding time was noted to be subjectively prolonged. Before proceeding with surgery, buccal mucosal bleeding time, prothrombin time, and activated partial thromboplastin time were checked and found to be within normal limits. Tranexamic acid was administered to reduce further bleeding. The durotomy revealed large blood clots compressing the spinal cord. The clots were removed and the dura mater was left open, with gelatin-absorbable powder and sponges used for hemostasis. Postoperatively, the dog received fluid therapy, pain relief, prednisolone, and tranexamic acid. 2 days post-surgery, the dog developed unilateral epistaxis which resolved with intranasal adrenaline. 2 days later, another epistaxis episode occurred, and was treated the same way. A computed tomography, or CT scan, of the head revealed no abnormalities. 3 days post-surgery, the dog developed fever and malodorous urine. A cystocentesis revealed no bacterial growth. The prednisolone dose was increased to 2 mg per kilogram daily, due to the persistent fever, the epistaxis, and suspicion of SRMA based on CSF results. After increasing the dose of prednisolone, the dog no longer had a fever or epistaxis and began to show improvement in her pelvic limbs. Her CRP concentration returned to normal. The dog was discharged 7 days postoperatively, non-ambulatory paraparetic but with some voluntary movement in her pelvic limbs. She was prescribed prednisolone at 2 mg per kilogram daily for an additional 3 weeks. 3 weeks later, the dog was still non-ambulatory paraparetic but with good voluntary movement in both pelvic limbs. The prednisolone dose was continued for another 2 weeks before tapering, and weekly physiotherapy was started. 3 months after surgery, the dog was ambulatory with no ataxia and was receiving hydrotherapy and physiotherapy. The dog's response to corticosteroid therapy supported a diagnosis of SRMA. The discussion section notes this case is an unusual presentation of SRMA, due to the epistaxis, spinal hemorrhage, and absence of cervical or thoracolumbar hyperesthesia. The diagnosis of SRMA was supported by the dog's blood work, CSF analysis, and response to corticosteroid therapy, despite the atypical presentation. The authors suggest the epistaxis may have been due to a systemic vasculitis involving the nasal vessels, as vasculitis has been seen in dogs with SRMA. A study of epistaxis in dogs found that 1 case out of 176 was due to vasculitis. Other possible causes of epistaxis such as neoplasia, trauma, and rhinitis were ruled out by a CT scan. Although a nasal biopsy was not performed, the lack of further epistaxis episodes once immunosuppressive doses of steroids were initiated suggests a link. Spinal hemorrhage from non-traumatic causes is uncommon in veterinary medicine. A study of non-traumatic spinal hemorrhage found that 20% of cases were due to SRMA. In this case, the dog was tested for Angiostrongylus vasorum with a negative result, but the authors note that the test has moderate sensitivity and a false negative may be possible. It would have been ideal to perform further tests like a Behrman test or thoracic radiography to ensure a false negative was not obtained. Previously reported cases of SRMA with spinal hemorrhage involved the cervical spinal cord, causing tetraparesis. This case is the first report of intradural hemorrhage in the lumbar spinal cord secondary to SRMA, resulting in non-ambulatory paraparesis. Previous reports described both surgical and medical management of SRMA-related spinal cord hemorrhage. The decision to pursue surgery in this case was due to the acute deterioration of the dog's condition. The authors acknowledge that a more comprehensive coagulation investigation prior to surgery would have been beneficial. Although the dog's blood work at her primary vet demonstrated mild thrombocytopenia, it was considered secondary to platelet clumping. The dog's blood was rechecked at an external laboratory and was found to have normal platelet counts. The use of tranexamic acid and topical hemostatic agents were used during surgery to reduce further bleeding. Gelatin material sealing sheets may be more successful at inhibiting inflammatory response in a surgical field compared to fibrin sealing sheets, and topical hemostatic agents in veterinary neurosurgery are worth further study. Another unusual feature of this case was the absence of cervical or thoracolumbar hyperesthesia, which is a common clinical sign of SRMA. A study of acute SRMA found neck pain in all dogs. However, a long-term study found that only 80% of dogs showed neck pain, suggesting that its absence does not rule out SRMA. The elevated erythrocyte count in the CSF sample might be due to iatrogenic contamination during sampling. However, even after correction formulas, white blood cell and protein levels remained elevated, supporting the diagnosis of SRMA. The typical treatment regimen for SRMA involves an initial high dose of prednisolone followed by tapering doses. However, immunosuppressive doses of corticosteroids can delay wound healing and increase risk of infection. The authors discussed the risks with the dog's owners who made an informed decision to proceed with corticosteroid therapy. The possibility of infectious causes of NTSH was considered unlikely. In retrospect, testing for toxoplasmosis and neosporosis would have been beneficial. In conclusion, this report details a rare clinical presentation of suspected SRMA, with epistaxis, intradural-extramedullary haemorrhage, and absence of cervical or thoracolumbar hyperesthesia. The diagnosis of SRMA was supported by the dog's blood work, CSF analysis, and response to corticosteroid therapy. The dog was successfully treated with surgical decompression of the spinal cord, immunosuppressive doses of prednisolone, and physiotherapy and hydrotherapy. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.